Hi, every doctors. My name is Inseong Jeon from Korea. I am a director of the SNH Dental Clinic. Before starting my presentation and live surgery, I want to give a big gratitude to the Megagen implant. So, briefly, I want to talk about the today live surgery patient case. There are many systems in the Megagen implant: the ST implant, Anyone, AnyReach, and then the new product is the Blue Diamond implant. So today, my first live surgery is the 69-year-old male patient. This patient systemically no problem. As you can see, this panoramic view. Let's check the first one, the sinus floor. Upper left side, maybe the residual bone. It looks like a 3 or 4 millimeter. And then the lower right side, this healed ridge area, very simple case maybe. And then lower left side, this immediate placement. Today, my treatment plan is upper left side, 2 implant, the blue diamond placement. And the lower right side, 2 implant, blue diamond. And lower left side is immediate placement. And then, so upper left side, the leaf expander with the universal kit. The new product, the leaf splitter. And then the lower left side is a simple GBR by the universal kit, by the wide cover cap. Let's check the Conbeam CT. So upper left side, as you can see, the residual, the crestal dimension, it looks like a 2 or 3 millimeter. So for a 4.1 or 4.4, the blue diamond placement, it require so leech expansion or leech splitting procedure. And then I will apply 2 blue diamond implant. And the lower left side, this is immediate placement. So the point is getting a good initial stability first. And then next one is a very simple GBR by the new product, universal kit, wide cover cap. The lower right side is a very simple case. Anyhow, today I will try install the 6 blue diamond implant. Wish me luck, please. Thank you.
Okay, as I mentioned earlier, now I'm going to start the live surgery. Today, first my visual interest is the upper left side. Usually after tooth loss, several years later, the buccal bore, the severe resorption, so it looks like some concavity area. So I want to make a flap design. The flap basic design is the top edge joint flap, the mid-crestal incision, a little bit including the keratinized gum tissue to the palate. Definite cutting is necessary. Number 12 blade, and then clavicular incision. 고기 조금만 더 오른쪽 그렇지. Usually require the volume increase, so you require the vertical incision, like this one. Okay, careful flap elevation. Okay. From the preoperative recombinability, this upper left side, the crestal dimension is very narrow area. Actually, maybe this area is a sinus area. So today I don't want the sinus surgery because the occlusion range from the first molar to first molar 6 to 6. Bone is very hard, it looks. So it require ridge splitting is necessary. Okay. The first one, the disc cutting. There are many instruments necessary, but my preference is just the number 700, the Fisher bar. This is the vertical bone cutting here. Wow, this is very sharp. Okay. And then the universal kit. This is, okay. 어머니, 목구멍에 있는 거 저희들이 다 빨아내는데요. 삼키셔도 괜찮아요. 아버님 좀 톡톡톡톡 치는 느낌이 드세요. This is the bone spreading action. Right here. And middle part. Sometimes the buccal plate total fracture. But there's no need to worry about because that means we have to change it to the GBR situation. This one, a little bit rotational movement here like this one. And then this the self-threading power is very excellent. So just like this motion without the grinding. 보세요. Rotational movement and spreading and the lever action like this motion. Okay, let's check the lingual wall section. Okay. The first drill. 저기 4.1 하나 준비해줘. 4.1 blue diamond, please. 여기 하나. (4.1짜리) 하나 있어. 그지? 4.1 거기 말고 저기 안에 있어. 거기 밑에 박스 안에. 해보세요, 아버님. Okay, first drill is the 2.5 drill. Next step drill 2.9. For a successful ridge splitting and the initial stability, the proper selection of the drill diameter is the first step. 4.1짜리 10 준비해 주세요. Okay, next step drill is 3.3. And then the second area, final drill 3.6. 요거 4.1인가요? 4.4도 하나 주세요. 4.4부터. Okay, today first blue diamond diameter 4.4. The ridge splitting area. RPM. Because of the deep thread design of the blue diamond, it's very easy to get the initial stability. For a successful result, in case of the ridge splitting, a little bit deeper installation is better. From the lingual wall is the guideline. So from the lingual, maybe a little bit 2 millimeter at least. Suction. Just 1 millimeter deeper, more deeper. 얘 블루 다이아몬드가 이게 가끔 안 맞더라고. Okay, initial stability is very good. Just what I want is the 30 Newton. Okay, next one. 4.1. 이게 4.1이죠? The anterior part, because of the bone concavity, so maybe sometime the total fracture of the labial plate, no problem. We change it to the RPM. At this time, still same guideline from the lingual wall, 2 millimeter deeper is better. Okay, self-stretching power is very good and very good initial stability. At this time, we have to determine this is the buccal fragment removal or not. If we want remover, that means require bone crushing and then the GBR technique here. At this time, you check the stability here. It's good. So at this time, just I wanna bone grafting same time. The membrane. Usually conventional GBR require bone tech fixation, but ridge splitting area, this is self-contained defect already, so just the holding suture is necessary, sufficient. And then even though if you can get a good initial stability, ridge splitting area cover screw is better. So I apply the cover screw. This is the self-contained defect. 요거 셀라인에 좀 번호야 돼. This is the bone matrix from the Magazine company. This is the biphasic calcium phosphate. HA component 60%, and then the beta TCP 40% here. Just covering the self-contained, the intentional defect area. Just the packing is okay. And then outer surface, 저기 저 xenograft 이 좋은 걸 꺼내는 거, 바트리에 있는 거 좀 더 주세요. 내가 꺼내놓은 거 있지? 그 이전 걸 우리 늘 쓰는 거. 더그라프트. 오케이, 그죠. 쭉 봐, 그냥 쭉 봐, 그냥. 됐어, 셀라인. This genograft is the bone contour maintenance. So sometime you can apply one more time as a second layer. 여기 셀라인 좀 보죠. 줘. PRF 주고. Small squeezing like this one. I think that this is the PRF, the space keeping for the lower dam area. It's very good for here. And then the superior part, I will cover the collagen membrane. If this is the conventional GBR, definitely require bone tech fixation. But this is the ridge splitting area, just the holding suture is okay. Let's try the flap approximation. Okay, require tension releasing. Like this manner. Okay, I want to increase the flap mobility. Okay, first step, horizontal matrix suture. Horizontal matrix from the start from the lingual, the palatal maybe 6 or 8 millimeter position. And then the buccal area, the partial engagement of the periosteum, 이거 살짝 이렇게 들어가. Okay. And deep side, partial engagement of the buccal periosteum, like this one. At this time, please very gentle holding the membrane right here. One more say, if this is the real GBR situation, it requires bone tech. But this is a ridge splitting, just the holding suture is okay. This holding suture provide the flap stabilization. Okay, flap approximation is very good. So, my second knot, I want to try the anchor suture. Anchor suture is very effective in case of the vertical incision area. So, starting from the buccal papilla here, and then surrounding the natural tooth, right here. And then re-entering out to the lingual side. This anchor knot is very good for the flap mobility, increased approximation to the natural tooth area. Always remind, the suture is the final touch of the surgery. So make a perfect knot making is a key point for the GBR or ridge splitting area. This is the mucoidal junction area. I will make one suture, vertical incision. 수술 시간 20분 되면 누가 하나 저한테 알려주세요. Tension loosening is not proper You have to check my left hand here, like this one. I have a tension control this area. This is the movable mucosa, so maybe it's not difficult to make a flap closure, the vertical incision area. Always check the flap control just by the tension here. Today, my first area, upper left side, I tried the reach splitting by the universal kit reach splitter, and then the 4.1 and 4.4, the blue diamond. Usually loading time is the 6 months later. We'll deliver the final processes. Okay. The remaining area, just a simple interrupt suture is okay. 거즈로 여기 본 파티클 한번 닦아줘. 아버님 아주 잘하고 계세요. 제가 처음에 계획하던 대로 잘 되고 있고요. After this area, the next area, lower right side, healed ridge area. 아버님, 오케이. 이거 12번 블레이드 하나 바꿔줘. Okay, this is final suture of the upper left side. Okay, I want to change the patient position. 아버님 입 다무세요. 자, 이제 자세 좀 바꿀까요? 아버님 이제는 턱을 밑으로 목적으로 당기셔야 돼. 그렇지. 아이 보시고. 오케이. 체인지 칼 갈았니? 랑겐백. This lower right side, just the heel ridge area. It looks good. So just a mid-crestal incision conventionally. 아버님 고개 약간 밑으로 턱 쪽으로 쓱. 그렇지. I think that this area no require vertical incision because the heel ridge and then bone amount, it looks good. So just only mid-crestal incision and then clavicular incision. And then my favorite incision design is the lower distal area, Y incision. Okay, this is the Y incision here. Y, the alphabet Y here, like this one. This Y incision means it's very provide good flap elevation, buccal and the lingual side. Bone is very irregular, so I already prepare some the denture bar, just like a crestal flattening drill. Okay, looks good. 잡아줄까? This crestal remover drill is provide a very good, clean the operation field. This is the canine, the first premolar, and then first molar here. Okay, I want to make a marking the position. 해보세요. 오픈 와이드. 아버님 고개 약간 왼쪽으로 해볼까? 그렇지, 그렇지. This is the canine, so usually 4 millimeter. This is the optimal position of the initial drilling. Drilling here. And then this is the 7 millimeter. This is the second premolar. And then this is the 11 millimeter. So first molar area here. This is the first molar area. Suction. This is the first molar. 잡아줄까요? 4.8에 10mm 하나 준비해줘. 거기 4.8. 아버님 아예 보셔요. 이거 좀 풀린 거 좀 풀려줘. 잡아주고. 아예 보셔요. 오케이. 잡아주고. I wanna use the extension drill because the interfere the adjacent tools. So extension. 아예 보세요, 아버님. This is the very good autogenous bone. So please don't waste this one. You can keep this one. So this is the magazine drill. The autogenous bone from this drill. If you collect this one by one, maybe you can get a very sufficient one. Okay, next one. 3.6 drill. 해보세요. 이거 잡아줘. 이거 줄이 라인 좀 풀어야 돼. 해보세요. This autogenous bone, I will use the lower left side. Okay, next step, 3.9. 해보세요. Please get this autogenous bone. Okay, second one. 해보세요, 아버님. Okay. This is the 4.3 for the first molar area. Don't waste this one. This is the 4.8. Bone density looks like a D2 and D1 middle part. So I think there's this kind of the cortical drill is necessary. And then anterior part, this is the 4.1. Bone is very hard bone. Because the optimization of the initial stability, it requires proper drilling right here. 오케이. 4.4 하나, 4.8 하나 주세요. 4.8. Okay, first lower right side. This is the 4.8, the blue diamond. 해보세요, 아버님. Okay, it's a very good initial stability by the torque wrench. Okay, very good stability. Just like maybe 20 Newton and 30 Newton here. 힐링 캡. 잠깐만요. Okay, this is the angulation guidance. 4.1 어디 있지? 4.1? 4.4. This the blue diamond self-threading power is good. So at the time of the implant placement, you can make some good angulation like this one. This is self-threading power. This is the buccal wall slightly thread exposure. Very small GBR. At this time, I like use the wide cover cap because the wide cover cap no require in case of the small GBR. So at this time, you place, if the stability too high, reverse torque here. One more try. This wide cover cap provide a very small GBR here, like this one. No require barrier membrane. And then at this time, I already got some autogenous bone. 이렇게 당겨볼까? 아버님 고개 약간 왼쪽으로. 그렇지. The reason why I make this kind of the wide cover cap, that means the small GBR area. 아버님 살짝. Okay. No require membrane. Just only wide cover cap is okay. And then slightly bending here. Like this motion. 여기 이종을 아까 더 그래프트 좀 더 줄까? 조금 더. 됐어. 사라인. This is the general graft. Very small amount is okay. Small amount. 아버님 너무너무 잘하고 계시고요. This molding of the wide cover cap here. Okay. 자, 이제 봉합할까요? The lower right side, I want to use the 아버님 아이 보세요. 오케이, the healing cap. 오케이, suture. 아버님 이제 두 번째 부위도 끝나갑니다. This is the no vertical incision. So full flap closure is impossible, but it's okay. Because too many times I already comment, this kind of the wide cover cap, even though exposure, absolutely no inflammation. So just a simple closure is okay. This is the maybe semi-submerging suture, semi-submerging, like here. If we use the healing cap, then it's the non-submerging. If we use the cover screw, then means the submerging. But this kind of the wide cover cap, semi-submerging here. No membrane here. 제가 요거 봉합할 때 조금 화면을 가릴 것 같은데, 오케이. Just only simple interrupt suture is okay. (40분) 되면 얘기해줘. 아, 보셔요. 오픈 와이드. Okay, 2 knots is left lower right side. 아, 해보세요, 아버님. Okay, final 1 knot. The most distal area. 아버님 뒤쪽이 돼서 조금 크게 한 번만. 오케이. Okay, this is the final knot. The lower right side. 아버님, 아. 아버님 이제 오른쪽으로 돌리셔야 돼. 아, 해보세요. 자, 이제 오늘 마지막 부위입니다. 아버님 고개 이렇게, 그렇죠, 이 정도. Okay, today final area, lower left side. This patient, from the first premolar, I want a total tooth take out. This is the third molar, second molar. This is almost floating. This is the first molar, second premolar, first premolar. Okay, usually this kind of the immediate placement, careful flap design, just like cutting the papilla first, and then you have to determine with vertical incision or not. It depends on remaining surrounding wall. So initially, without vertical incision first, flap elevation first. I think that it looks like a very good self-contained defect area. Right here, this is the first molar area. Very easy situation, I think. Because the too severe periodontitis, very interestingly, bone looks good for implant placement. So I think the no require the vertical incision. For a successful immediate placement, first step, lingual area drilling is the first step, lingual side. So at this time, first one, of course, curettage here. This second premolar, this first molar area. Optimal positioning, a little bit difficult. Okay, by the side cut drill. Very fortunately, we have a very good side cut drill in the blue diamond kit. 4.4 하나, 4.4 두 개 꺼내줘 이제. 아버님 아예 보세요. This is the canine. Canine a little bit medial tilting here, but I want to try this direction here. This is side cut. 여기 suction. This drilling is important here. Okay, suction. And then this first molar area, the midpoint. At this time, for a good angulation matching, first molar installation first. 아버님 많이 보세요. 여기는 먼저 16을 끝내야 되겠다. Okay. 40 minutes have passed. This bone I want to collect. And then 3.9. 아버님 And 4.3. This is the final drill. 아예 보셔요. 4.4 임플란트 주시고 이건가? RPM Initial stability looks perfect. Perfect initial stability. Depth control. Okay. RPM 올려주고 with this angulation right here, the lingual side, not this area. This lingual is the key point. Next one, 3.3. 네. Bone looks like some soft, so my final drill 3.9. Okay, today final implant 4.4 blue diamond. Okay, this is good angulation. Just maybe about the 20. So at the time of the hands talking, I want to increase the about the 30 Newton here. This is also very small GBR. So no require the barrier membrane. Also, I want to use the wide cover cap. This is a very small GBR. No require barrier membrane. 힐링 캡 하나 꼽을 거야. The posterior area 힐링 캡. Okay, almost done today live surgery. 이거 말고 아까 그 블루 다이아몬드 그 통 좀 잠깐 줘볼래? 그거 그 와이드 커버 캡 있는 거. 와이드 커버 캡, 블루 다이아몬드 와이드 커버 캡. 아까 보여줘. Okay, I wanna select the proper the over contouring because this maybe about 2 millimeter or 3 millimeter is okay. 2 or 3. It's good. This is the 3mm over contouring here. 저기 이종걸 더 그래프트 좀 더 줘요. 아버님 아예 보시오. 오케이. 좀 더. 됐어. This also no require barrier membrane. Just simple insertion is okay. Right here. Yes. Okay, suture. 아버님 아이 보셔요. 오케이, 오케이. The papilla is intact. So sometimes papilla zigzag suture, sometimes the conventional suture, according to the flap mobility. Right here. This is the semi-submerging fashion. Semi-submerging. Like this manner. Partial exposure is good. Cut. And then this area, after surgery, this patient take a panoramic view and the conveam CT, and then I will wait for your answer. for your question. Okay, today final knot. 몇 분 됐죠? 아버님 고생 많이 하셨어요. Okay, I finish today's surgery. Thank you for the patient, and then thank you for your great support of the magazine implant. I moved my room, and then I wanna wait and then answer ready to your every question. Thank you, guys. Hi, every doctors. Thank you for joining this Magazine Live surgery course, surgery webinar symposium. So this is the right after surgery. I take a panoramic view, and then I want to share this one. This area, the upper left side first. This is the canine. This is midline and the canine. So this area, I want to make some the occlusal the range like here. The first molar to the first molar area, and then these two implant. As you can see, this is the ridge splitting area, ridge splitting, and then I got a good initial stability. So simultaneous implant placement, and then this the lower left side, lower right side. This is the healed ridge area, but maybe buccal wall slightly resorption. So after implant placement, we meet just maybe buccal thread 2 or 3 thread exposure. So there is a small GBR. So I apply the wide cover cap, and then only the bone filler. Just the bone matrix and the xenograft. And the lower left side is same. This is immediate placement. Of course, very simple immediate placement because the usually good self-contained defect. So also, this the lower left first premolar area. Just I only apply the wide cover cap with the bone filler only, without barrier membrane. Okay, now I want to answer your question. Your first question, difference between the normal cover cap and the wide cover cap. Actually, the GBR, there are 3 components. So 3 components means this is the cover screw, healing cap. And then one more thing, wide cover cap. And then second factor is the membrane selection. Membrane, resorbable membrane or non-resorbable membrane. And then final one is stabilization. Stabilization is sometimes the holding suture or bone tech fixation. Anyhow, this cover cap, healing cap, wide cover cap is different because cover screw, this is the submerging situation, and then healing cap, non-submerging situation, just like a divergency. But my point is, just like here, and then like this one here, and then this means just to make some the space for the consolidation space. So if we use this one, this is totally different. Cover screw, healing cap is different. That means the special characteristic of the wide cover cap. So the main focus of the wide cover cap, first one, small GBR, only wide cover cap with bone filler. Large GBR, instead of the non-resorbable membrane, wide cover cap, resorbable membrane, bone filler. So anyhow, this kind of my presentation, I already lectured several times to the world. Anyhow, for a more deeper knowledge and the concept and the technique, I will let you know the next time. The second question, how do you select the wide cover cap screw size in the minor GBR? That means wide cover cap, I make a 3 diameter, 6 millimeter, 7 millimeter, 8 millimeter. And then over contouring, 2 millimeter, 3 millimeter, 4 millimeter. Usually, premolar area, 6 millimeter is okay. And then molar area, 7 millimeter or 8 millimeter is optimal. This is the premolar, this is the molar area. And then over contouring selection according to your depth. Sometimes deeper installation, you can select 4 millimeter over contouring. Or from the lingual wall 1 millimeter deeper, you can select 2 millimeter over contouring. The third question. Of course, previously several times, many times I used the piezo surgery, and then we know the piezo surgery is very good, the instrument for the ridge splitting, but sometimes a little bit complicated because the armamentarium a little bit very expensive, and then the equipment, the preparation is a little bit complicated compared to disc. Your point is very good. That means the ridge splitting anyhow. This is the 3 millimeter dimension usually, like here, and then initially horizontal bone cutting like this one. At this time, this horizontal bone cutting dimension, bone disappear. If we use the blade, bone disappear very small. If we use the the disc usual thickness is the 0.4 millimeter. And then if you use the piezo surgery maybe 0.5 or 0.6 millimeter. If you use the number 700 Fisher bar, maybe about 0.8 millimeter. Anyhow, according, third question means, I would like to ask you why you prefer to use the disc for the ridge splitting instead of the piezo machine. I think piezo machine can ridge splitting more easily and smoothly. That's right. So I think, I answered already. The price of the equipment and then the preparation of the equipment is very complicated compared to disc. So I think I already used the blade, sometimes disc, sometimes the piezo surgery or number 700 Fisher bar. But I think the more important one is this dimension. So easy approach. I want a frank talk with every doctors. For the easy approach, I think disc is the very, very easy to use. If you blade the piezo surgery, many advantages, we agree this one. So at this moment, it's very difficult to discuss pros and cons, each disc and the piezo surgery. Of course, both of them is available for ridge splitting. Number 4 question. You place the implant immediately after tooth extraction. Do we still need to have primary stability in your case? Definitely. Most important strong factor for a successful immediate placement is initial stability. Your question, if we didn't get initial stability, do we need to wait for with bone, GBR, or graft? This is socket preservation. Okay, I briefly answer. Socket preservation, please. No bone grafting, please. If you want delayed placement, because the reason is only one, we cannot get an initial stability. That means the delayed placement is better. But at this time, for socket preservation, first one, please, barrier membrane only is okay, without bone filler. Because patient healing potential, self-bone healing potential, if you put some bone filler to the extraction socket area, usually interfere the bone regeneration. So I strongly recommend, if you want delayed implant placement, please membrane covering only is okay. Or sometime severe infection area and then no remaining bone to the inferior canal or no remaining bone to the sinus floor area, that means nothing is okay. Just wait. Usually 4 months, at least 4 months, and then 6 months. And then 4 months and 6 months later, at the time of the delayed placement, you place the implant and then second GBR is okay. Why do you choose to partially cover when you use the wide cover screw? It's a very good point. I have a 4 years data of the wide cover cap. This wide cover cap, no exposure or total exposure or half exposure or quarter exposure, any situation, no inflammation, no infection occur. That means please don't try to full flap closure. If you know the reason, because you want to make a full flap closure, that means vertical incision and then tangent releasing incision. That means finally keratinized zone disappear and then vestibule lowering usually. So according to the situation, soft tissue situation and hard tissue, sometimes try the full flap closure, sometimes partial flap closure. Any situation, wide cover cap exposure make no failure. Number 6 question. According to the a lot of articles, we need to keep more than 2 to 3 millimeter bone on the According to the other article, we need to keep more than 2 to 3 millimeter bone on the crestal area when you do vertical bone grafting. So I would like to ask you, how we can be sure that we could secure the volume of the bone and the area with the cover screw, wide cover screw? Today my case is a very small GBR. Please remind. That means maybe bone looks like here. And then implant placement like this one. So thread exposure, maybe this is small exposure, small. Small exposure means thread, maybe 2 or 3 thread only. At this time, wide cover cap here, and then bone filler, and then bending here. And then just a soft tissue closure like this one. Sometimes full flap closure, sometimes partial flap closure. It's okay. No problem. Of course, more difficult situation like here. This situation, thread exposure amount is very big. That means wide cover cap, and then bone filler, and then membrane. And then also sometimes bone tag fixation is necessary. So according to the thread exposure amount, you can apply the bone filler only or bone filler with barrier membrane. Today is a very, I pressed for the time, so, but I really appreciate you guys joining this the Magazine Live Surgery, the webinar. And then, as an implantologist, I worked 25 years. And then I worked with many companies. But nowadays, recently, from the 5 years ago, I worked with the Magazine implant. And then I really happy to introduce the Blue Diamond. Just a very good connection. And then very good design for getting a good initial stability situation. So I sincerely hope today my live surgery will be helpful to every doctors. Thank you.